Welcome to Dr. Gore's show. So today we're going to talk about epilepsy beyond the stigma. Epilepsy, commonly known as seizure disorder, is really a common disorder which has a lot of cultural, ethnic, and voodoo kind of thinking attached to it, and to kind of come to know what's right, what's wrong, what's just a cultural kind of stigma attached to it. We're going to talk about it in detail with an epilepsy specialist, which are very rare to find. So on the studio, we have Dr. Gautami Rao. Welcome to Dr. Gore's show.
Thank you for having me.
So Dr. Rao studied medical school in Bangalore. Then she came to New Jersey, did her neurology residency at UMDGN, and then she went on to study epilepsy at Yale, and she's been in practice since 9 years, and presently she is at Eastern Regional, New Jersey Eastern Regional Epilepsy...
Northeast Regional Epilepsy Group.
Northeastern Regional Epilepsy Center. And so let's define epilepsy. What's epilepsy?
So epilepsy is when you have more than one seizure, and there isn't a clear known cause for it. For example, a lot of patients come in and they have one seizure, and it can be because of sleep deprivation or because of alcohol or because their electrolytes are abnormal, and we all see that in residency. But we use the term epilepsy when it's multiple seizures, and these can be because of a genetic cause, or it can be because of a tumor in the brain or a lesion that we can't see on MRI, but we can only see on pathology.
Right. So it's usually what's defined as like people start having like convulsions, right? Like the whole body gets really tight. Either they have frothing in the mouth and they have involuntary urination and stuff like that. That's usually what we were taught in medical school.
Absolutely.
And those are usually those grand mal seizures, correct? Right. But you could have different kinds of seizures where the patient just becomes still and they just have no activity as such, and they just kind of black out. So walk us through what are the different kinds of seizures.
So there's actually over 200 types of epilepsy, which is one of the reasons why I love it so much, because I feel like I learn something new about epilepsy every day. And it depends on which part of the brain the focus is coming from. So you have complex partial seizures, which are the most common types, and those start with a confusional episode. It can also be a sense of fear, or it can be laughter in some cases. There's a condition called gelastic epilepsy, which comes from a certain part of the brain where patients laugh, and they become very confused afterwards. So if it's a simple partial seizure, you experience something, but you don't lose consciousness.
Okay.
Complex partials, when people appear confused, they're blinking their eyes, or they're hearing voices, or they're hearing music, or even seeing images, and they're confused. And very often the complex partial seizures progress to the shaking types of seizures that we often see on TV, although now I think the media has been really doing a great job of looking at different types of epilepsy with all the different shows that are out there.
Right.
And within those complex partial seizures, there's 200 different types, because all different types of the brain present as different seizures.
Right. So we have different kinds of seizures which are, prevalent. How do you diagnose them? So usually the family member will notice there's some difference in the behavior, or they have these episodes after episodes. So they come to you, or they come to their primary care. What's the usual workup before you diagnose somebody with seizure disorders?
So the first thing, just like we're all taught in medical school, is history. And that is probably the most important part of epilepsy, because many seizures are not witnessed. So we really try to get a good story behind what happened, whether it's in the emergency room or in the hospital or in an outpatient setting. And that can be done through the use of talking to family, or looking at the chart, or very often talking to the patient themselves. EMS helps also. And then after that, we usually will order an EEG. And we do...
That's like a EKG of the brain. Where
Right, it's a brainwave test.
Correct.
And we use 16 leads, there's actually a very specific way of doing it, which is an international standard. Everybody all over the world does the EEG the same way. And then people that are trained in epilepsy, like myself, we read it. And you can have a 40-minute EEG, you can have a 24-hour EEG, a 3-day EEG, and the 3 or 5-day EEG can be done outpatient or can be done in the hospital.
Okay.
And then, depending on that, depending on the history, we choose to do an MRI of the brain. Now it's standard of care that every patient with a first seizure does require an MRI of the brain with contrast. That's what the American Academy of Neurology guidelines state, and I think it's a good idea. And you can do that in-house or outpatient. And then based on that, we decide on which type of medications we choose, and there are about 12 medications. The other thing we do is taking all this information into account. We look at the brain waves, and different seizures present as different brain waves. So, and there's different meds for each brainwave presentation. So the great thing is now there's 12 to 15 medications for epilepsy, so we can really pick and choose.
Right. So the MRI of the brain is like a CAT scan, but it's much more sensitive without the radiation. And the whole idea for MRI is to look for if there's any tumor, if there's any growth, if there's any cause why somebody should have new onset seizures, because then the treatment might be different if there's a growth which needs to come out and stuff. So we've done the basic 2 investigations with either the EEG, MRI, and now the patient has come back to you. How do you start giving them counseling? Because this is a life-changing diagnosis.
Yes. Well, especially with adolescents, it's difficult, and with women as well, because, well, in the first group, adolescents feel like they're all powerful. And an epilepsy is a very scary disease because you literally lose time. 1 minute you're in your room, and the next minute you're in the hospital, and you have no idea how you got there. So it caused a lot of anxiety, and in the adolescent population, they really don't want to take medications. So we really tell them that this doesn't have to be a life-changing thing. Medications work, they help, and you can go on with your daily life. And our job is to make sure that we choose the right medicine to make sure that they don't have side effects. So I tell them, leave that part up to us, and your job is to make sure that you realize that this is something which you can get beyond and you can live a normal life.
Right.
And with women, the special concerns are multifactorial. I mean,
absolutely. We'll come to the woman in a second, but so adolescent, as you brought it out, they have to be careful with swimming, they have to be careful with driving. So how do you counsel that part for adolescents?
Well, the most common type of epilepsy in adolescents is complex partial epilepsy. And the second most common is juvenile myoclonic. And both of these epilepsies are usually associated with normal intelligence, very highly functioning kids. So we tell them is once we get them on a good medication, they can drive and they can swim, but somebody has to be there with them.
Right.
They can't swim alone. So they can't just go off onto a beach and swim by themselves. They can bike ride. Hang gliding is probably not a good idea, and neither is jumping out of a plane or bungee jumping. But of course, this is what the patients want to do. So you have to tell them that this is a little bit risky. Now we have great medications that are not very sedating. So they're able to engage in athletics and do everything they normally do under our supervision.
So it's just a matter of counseling them that if they take the medication correctly and if their seizures are under control, they could go ahead and do day-to-day activity without limiting, but especially with high-risk behaviors like hand gliding and bungee jumping, we all have to be careful where we go from that. So, so let's go to medication. In general, there are, different kinds of medications in a different class of medication. We started with a really medication which had sedating effect and a lot of side effects to now which has limited, the use of it. But with the newer medication, we have taken off those side effects. So can you tell us in broad classifications of anti-epilepsy medications?
Sure. So there's an association called the International League Against Epilepsy, and it's the league that actually classifies epilepsy syndromes and helps with medications. So there's several different classifications. We should probably just look at the older ones and the newer ones. So the older drugs that we're all familiar with are Dilantin, phenobarb, Tegretol, quinine was used, primidone. You don't usually see quinine primidone used anymore, but you will, but you do see phenobarb and Dilantin used very commonly. Those are the older drugs. They're sodium channel drugs, and they cause a lot of side effects. They cause osteoporosis, and they interact with all of our medical drugs like Coumadin and digoxin. Then you have the newer medications like you have Lamictal, Topamax, and most recently Vimpat and Keppra. And now there's another drug called escalarbazepine, and several new drugs that are coming down into the pipeline. There was Patiga as well, but Patiga had some side effects, so it's still being worked out. So the newer medications, they have almost little to no effect on other medications that you can use.
Okay.
Or on each other. So Keppra and Vimpat are the two drugs that have no interaction with any other medications.
Wow.
So people that are trained in epilepsy, as far as possible, if it's appropriate with the type of syndrome they have, we try to put these people on those medications because they're not sedating, they're easy to use. Vimpat, you don't have to check levels, but Keppra you do, just to see what a good range is. And Keppra especially can be used safely in pregnancy. Even though it's not FDA approved for that, we do use it, and I've used it, and many other physicians have, and it really, the pregnancy goes well, and the kids are of normal intelligence, and it works out really well.
Right. So enlighten us, because most of the anti-epilepsy medication we used to always tell, because it went through the liver bypass, to be careful with, especially birth control pills and, other medication somebody's taking. Is the newer medication still goes through the liver bypass or no?
No, it doesn't. Keppra actually acts on a receptor called SVC2 in the brain, and Vimpat has a mildly sodium channel effect, but it inactivates the slow sodium channels, so it has a different type of effect. The thing is, though, is that this JME that I was talking about is a primary epilepsy syndrome. It's called primary generalized epilepsy. In those types of epilepsies, sometimes Keppra and Vimpat are not the best choice.
Okay.
Actually, some of the older medications like Depakote, Lamictal, Topamax, those are the first-line treatment.
Okay.
So these drugs are good, but that's why it's really important to seek the consultation of an epileptologist, because every epilepsy falls into a syndrome, and not every medication is equally created.
Effective, right.
But the newer ones are good because they don't really go through that pathway. And Vimpat does have some caution with liver failure patients, but Keppra does not.
Wow. So I think the world of epilepsy has evolved so much. We're going to take a short break and we'll be right back.